Hello and welcome to our bioinformatics report presentation.
Today, I'm walking through the key components of our integrated mutation expression analysis of bladder cancer. I'll start with the research question, then briefly outline our workflow, and then go into the hypothesis which we use to examine this topic. Our project asks how mutation-defined clusters in bladder cancer can give rise to transcriptional programs like immune activation, cell signal cycling, and luminal basal differentiation, and whether those combined genomic patterns relate to patient survival outcomes. Essentially, we want to know, do genomic clusters actually reflect real biological behavior, and do those behaviors matter clinically? To answer that question, our workflow integrates three major data types: clinical data, mutation profiles, and RNA sequence expression data. We first cleaned and merged these data sets, then derived mutation-based clusters and performed downstream analyses including pathway scoring, subtype classification, and survival modeling. This structure let us connect genomic abnormalities to transcriptional consequences and ultimately patient outcomes.
For hypothesis 1, we examined whether a patient's age at diagnosis influences their overall survival. To test this, we used clinical patient data and split patients into younger and older groups based on the cohort's average age. Using Kaplan-Meier survival analysis, we generated curves for both groups and compared them with a log rank test. As shown in the plot, older patients have consistently lower long-term survival, and the p-value of 0.014 indicates this difference is statistically significant. This supports our hypothesis that age is clinically relevant for survival outcomes. For hypothesis 2, we explored whether patient sex impacts overall survival. This was motivated by the fact that sex-based survival differences are well documented in some cancers, so we wanted to see if a similar pattern existed in BLCA. Using our clinical patient dataset, we generated Kaplan-Meier curves for male and female groups. A log rank test was then used to compare the two survival trajectories. As shown in the plot, the curves nearly overlap and the p-value of 0.5 indicates no statistically significant difference. These results suggest that, unlike other cancers, patient sex is not a major determinant of survival in this cohort. Before forming our next hypotheses, we clustered patients based on their mutation profiles. By focusing on the top 20 most frequently mutated genes, we reduced noise and highlighted meaningful patterns. In the heat map, we can see that TP53 mutations dominate clusters 1 and 2, while TTN is mainly enriched in cluster 1. In contrast, cluster 3 shows very few mutations in these genes, indicating a genetically distinct subgroup. For hypothesis 3, we determined whether the two most common mutations in our dataset, TP53 and TTN, could explain the survival differences observed across patient clusters. Since these genes dominated clusters 1 and 2, we tested their contribution using Cox proportional hazard models. We ran two versions of the model and calculated a hazard ratios within each cluster. As shown in the bar plot, hazard ratios are elevated, but the p-values for TP53 and TTN are 0.75 and 0.65, which are not statistically significant. This indicates that although these genes are frequent, they do not meaningfully explain survival differences between clusters.
For hypothesis 4, we hypothesized that TP53 and TTN contribute to stage 4 bladder cancer because they commutate with each other. To test this, we built a stage 4 specific commutation matrix and visualized the top 20 mutated genes as a weighted network, where node size shows mutation frequency and edge thickness shows commutation strength. In this network, TP53 and TTN clearly emerge as major hubs, with the largest node sizes and the most commutation links. TP53 also commutates with several additional drivers, forming a dense interconnected cluster typical of advanced tumors. Biologically, this pattern reflects significant genomic instability in stage 4 disease, with TP53 and TTN-centered networks likely contributing to tumor aggressiveness. These results support our hypothesis and highlight TP53 and TTN as key components of stage 4 mutational landscape.
For hypothesis 5, we focused on two chromatin-modifying genes, ARID1A and KDM6A, which are frequently altered in bladder cancer. The motivation here was that chromatin regulators often shape large-scale transcriptional programs, so if they contributed to tumor progression, we might expect to see their mutations enriched in stage 4 disease. When we compared mutation frequencies across stages, however, the rates were nearly identical between early-stage and late-stage patients. Fisher's exact tests gave p-values around 0.54, indicating no statistical association. So, despite their biological importance, ARID1A and KDM6A mutations are not markers of advanced disease. The key implication is that these genes may influence tumor development or phenotype, but they do not appear to drive progression specifically towards stage 4 cancer. Based on this, we rejected this hypothesis.
For hypothesis 6, we hypothesized that TP53 and FGFR3 mutations are mutually exclusive between cluster 2 and 3. To test this, we compared mutation frequencies across clusters and ranked genes by differential mutation rates, supported by feature-exact test. TP53 is strongly enriched in cluster 2, while FGFR is enriched in cluster 3, with very few tumors carrying both mutations. This opposite pattern reflects distinct oncogenetic pathways in bladder cancer, and based on this clear separation, we accept this hypothesis. For hypothesis 7, we hypothesized that patients with RB1 mutations will show higher expression of cell cycle genes, particularly E2F targets and G2M checkpoint regulators. To test this, we classified patients as RB1 mutate or wild type and computed E2F and G2M signature scores from hallmark gene sets using VST normalized RNA-seq data. Across both signatures, RB1 mutate tumors show noticeably higher expression levels, consistently with loss of RB1-mediated cell cycle control and increased proliferative activity. These results support the hypothesis that RB1 mutation drives stronger activation of cell cycle programs.
For hypothesis 8, we tested whether TP53 mutations change TP53 transcript levels. Since TP53 is one of the most commonly altered genes in bladder cancer, we wondered if mutation-heavy groups would show reduced expression. The results show that TP53 mutant and wild-type patients have almost identical expression distributions. The p-value is statistically significant only because of the large sample size. Biologically, there's no meaningful difference. This tells us that TP53 mutations disrupt function, not transcription. The mRNA level stays essentially the same, so the expression alone can't be used as a marker of TP53 functional loss. For this reason, we rejected this hypothesis.
For hypothesis 9, we hypothesized that INFA-gamma and PD-1/PD-L1 immune signaling pathways are differentially activated between clusters. Using VST normalized RNA-seq data, we calculated INFA-gamma and PD-1/PD-L1 signature scores for each patient and compared pathway activity across clusters. Cluster 2 shows the strongest immune activation, with higher INFA-gamma and PD-1/PD-L1 signaling, consistent with an immune-hot tumor microenvironment. Cluster 1 and 3 display much lower pathway activity, reflecting more immune-cold or suppressed states. This pattern supports the hypothesis and suggests that cluster 2 tumors may be more responsive to immune checkpoint therapy. For hypothesis 10, we hypothesized that our cluster reflects real biological differences in bladder cancer, with some clusters dominated by luminal tumors and other by basal tumors. Using VST normalized RNA-seq data, we computed luminal and basal marker scores for each patient and assigned subtypes based on which score was higher, then compared survival between the two groups. Luminal patients show significantly better survival than basal patients, with a clear separation in KM curves and a higher significant p-value. These results support the hypothesis and confirm that molecular subtype is a strong predictor of patient outcome.
For hypothesis 11, we asked whether tumors with higher cytotoxic immune activity show better survival. Immune scores did vary across clusters, confirming real biological differences in immune infiltration. But when we stratified patients with immune high and immune low groups, their survival curves were almost overlapping, with a non-significant p-value of 0.19. So even though some tumors are more immune active, that activity does not translate into improved prognosis on this dataset. This suggests that immune infiltration alone isn't a strong predictor of survival in bladder cancer, and we rejected this hypothesis. To close, our results show that the real mutation-based clusters reflect biological patterns, like cell cycle activity, immune signaling, and luminal basal identity. Even when some hypotheses didn't hold, the clusters still revealed meaningful tumor behavior. Overall, this project shows the value of combining mutation, expression, and clinical data to understand bladder cancer. That concludes our presentation, and thank you for your time.